hopefully everybody listened to the first part so they got all the details.
None of us started out really knowing these things. My research was on mandibular setback surgeries and the effect on airway and facial aesthetics. I saw something in those patients that wasn't favorable. Cone beam came, and that was when anatomic truths were obvious. That's really when it hit the sky. The skies opened up and we learned. I think cone beam utilization is an absolute yes. There's just so much we can't see and understand. They're important, they're revealing. It's standard practice, it should be. I think we have to have it, and colleagues that don't have it probably don't know what they don't know. It's just necessary. I couldn't operate without it. I think DICE is important in some of the specific cases, but I rely more on my clinical exam than anything. In a deep screening questionnaire, the video of sleep, everybody should have a speculum. I just think everybody in orthodontic practice should look up the nose.
How many people go to the orthodontic appointment, the orthodontist looks in the nose?
I do rely on the PES. If somebody's having a sleep study, I'm going to refer and ask the patient to get a better sleep study than just HST or something like that. And so that is a level up that most of us probably don't know about or aren't using that I think really should be utilized more. If I don't know, I'm going to rely on my colleagues too. I mean, this is a team effort. The patient, they're going to be sensing that something more thorough is happening here. And I'd rather be the last office in a series of opinions because I think we're going to win them over. And not that it's a contest. It's a matter of doing the right thing, the best thing we can for each patient. A lot of us are feeling incomplete by the AO white paper, and we want to do more, and they're challenging us to do more, but we are doing those things and not routinely. We have trouble going through the primary care person. They usually don't understand. Usually it's a barrier. Usually it's a dead end for us, or at least a roadblock. We're going to go into some kind of therapy, some kind of appliances, and get something started. It helps them know that I understand a little bit deeper about what sometimes the colleague isn't quite up to speed with what we're doing. If there's ENT concern, that's a priority. Maybe they think this is OSA, it's an old person problem. So it takes a lot of education there. Quite honestly, there's a lot of times they don't do it, and yet we've got to intervene. There are things that need attention to get this kid sleeping, thriving, breathing better. I don't want to wait months to help the child, so we'll intervene.
You created the Grummons protraction face mask. Can you talk about where it's affixed on the face and why you feel that's more beneficial than maybe having chin cup or other components?
Well, actually, the ones that are on forehead and chin are very beneficial. It's just that compression on the jaw then translates to compression at the posterior attachment within the joints. That's not a load-bearing zone. Our jaw is meant to be moving, not just in a sustained load. So it's compressive loading, and it's sustained, and it's for hours. About 24% of the patients that he followed that had chin cup loading had an internal derangement at maturity. That caught my attention because it supported getting off the chin. That was in the late 80s, and that's when I had the prototype of this, and then finally the design. Being a TMJ guy for a lot of years probably had more impression upon me to consider that. But if somebody is using the chin load, I'm not going to be critical of that.
Does that impact face development?
That's the misunderstood part. Yes, it does. And so we don't use it on a 1 or 2 or 3 year old because of that factor. It's more important to not have compression in that area as it matures. So it's inappropriate to do it before age 2 or 3. This is an area that's not intended to move. We're not going to have pressure there and displace the orbit somehow. Zygomatical maxillary suture is very tortuous, highly convoluted. So it's meant to not change. It can take support, it can take compression. Get on the midface early though. If the child's got a deficiency at 2, 3, 4, begin the process. And if your choice is to use the chin load, I'm okay with it for the sake of the child getting some help.
What about adults who are doing MARPE and using protraction face masks?
If I had to choose, I would say do one-step surgery correction because it's for sure. If it needs to go forward 4 to 6 millimeters, I can't do that with a face mask and a MARPE. We certainly have used it, but we use it with SARPEs. We avoid extractions because I want to develop the arch early. The brachyface, we almost would never extract. I lean real heavily toward not taking teeth out, not because I want to champion and get on stage and say we never take teeth out. I think there's a diagnostic untruth in saying that we never have to do that because some of the faces need that. So we don't criticize our colleague unless we know the shoes they're walking in. But if it's a case that's clearly non-extraction, then it's a different story. From failures. Failures teaches us a lot.
Can you talk about why it might be important to do transverse expansion even when there's no dental crossbite?
The lower arch can be leaned in without posterior crossbite. The upper might appear to be wider than the lower, but it might be that the uppers are leaned in, compensated in, and then the lowers are leaned in even more because the top is the lid on the box. So the upper might not be in crossbite with lower posteriors, but the lower, when they're upright and brought to the axial inclination they should be and the width that they should be, then the upper has to be made to match that. And the lower could be the limiting factor. The upper is always going to be made wider, but it's going to be with the lower lower arch upright transversely. That's our guide clinically.
So our patients that are just getting RPE on the upper arch might not be enough.
Both arches need to be expanded. Let's look beyond just the upper. If we did all this in our first phase, the adenoid clearance is going to be better. The flow is going to be different. The resistance different. The turbulence different. So the adenoid might be less important if we're nasal breathing at that point. The moment that I had a speech pathologist in the office, it was just like, whoa, how could you not include this? It makes such a difference in my case success or what I can do for the patient by including that. We're in this together. Speaking from the tongue space, that's a beautiful way.
Yeah.
Hopefully have them see it a new way. It is difficult. You can lead them to water and can't make them drink necessarily. Yeah. You want that patient to get the best. And so you feel that commitment and that sense in your heart. On page 23 of the white paper, I think there's a reasonable challenge that the authors gave us, and we need to respond to it. It says, what craniofacial variables contribute to the pathogenesis of OSA? What airway function is affected by orthodontic treatments? And that could be favorable or unfavorable. What are we doing that affects it? At what age? And does it progress from childhood to adulthood? Does it prevent OSA in adulthood if we enter early? And what are the endpoints for therapy? I think these are reasonable 6 questions that they're challenging us to give the data to. And so I've mentioned several times, let's verify, validate what we're doing. Let's share it, publish it. Let's put it in peer review journals, because that's where it has some strength and traction. They're challenging us to say, give us the data and we'll listen. I'll take those challenges and let's respond.
Yeah, let's do it.
Let's do it.